Are we good on screen sharing? You guys see the slides?
Yep.
Cool. Okay. Thank you all for being here. We are the Healthy Hackers. We are Kai, Jordan, Christina, Omer, Stephen, and Melanie. And we're going to be talking to y'all about access to healthcare and outcomes from the pandemic. So our research question going into this was basically to see how the health outcomes of people who would be considered underserved by the medical community varied from the health outcomes of everybody else. So what does it mean to be underserved by the medical community? Well, the HRSA, the Health Resources and Services Administration, has a couple of different designations for what it means to be underserved. One of these is medical professional shortage areas, MPSAs, and this is based on availability of care. So if an area has very few physicians per capita, they might be considered underserved in this particular way. The other designation that the HRSA gives out is medically underserved areas. This is based on the needs of the population. So if a population has high need of medical care and that need is not met, for example, if they're like an aging population, then they would need to have a great access, like high access to medical care in order to not be considered a medically underserved area. There's a lot of different measures that go into how the HRSA makes these designations. To keep things simple though, we just focused on counties that have a high rate of poverty and counties that have few physicians per capita. Just to give you a sense for what kind of questions guided us through our analysis, we wanted to first focus on our population. Who are the people that we're interested in? People underserved by the medical community. What is it about them that we want to understand? We wanted to keep it simple, focus on deaths from COVID and cases, COVID cases. There are a couple of different sort of like mechanisms that we looked at in terms of like how they could affect the different outcomes that medically underserved people experience from COVID. Those are the extent of the local COVID response and the local vaccination rate. And how do we do it? We looked at county level data across the US. I'm going to kick it over to Christina to look through some of this data.
Thanks, Omer. Sorry, I had problems with microphone. So first we looked at who actually lives in the areas with high poverty or low access to physicians areas, just so that we know who we're actually talking about. And to that end, we correlated counties' demographic characteristics with the poverty rate and the number of physicians per capita. What we found is that the higher poverty rate correlates with a higher percentage of the Black and Native American population, and to a lesser degree with a higher percentage of rural households. A lower number of physicians per capita correlates with a higher percentage of rural households. And for the rest of our analysis, we designated counties belonging to the top 10 percentile of poverty rate in the country as high poverty areas. And similarly, we designated as low physician access areas counties in the bottom 10th percentile of the number of physicians per capita. Next slide, please. In terms of COVID outcomes, we look at COVID cases as a measure related to COVID exposure and COVID deaths as percentage of confirmed cases as a measure related to healthcare access. We also look at these outcomes separately for 2020 and 2021, as 2021 also includes the impact of vaccines. In the graphs on this and the subsequent slides, the red graph indicates a vulnerable population, whereas gray graphs represent everybody else. And here we present data for high poverty rates. We found that on average, people living in these areas were contracting COVID more often, and they were more likely to die of COVID than people living in other countries. The disproportion in death rate only grew in 2021, and all these differences are statistically significant. Next. In low physician access areas, we actually found that the only statistically significant difference between the vulnerable population and all other counties were in death rates in 2020. So it's really interesting observation that among the two measures we took, poverty is what really makes the difference. Next slide, please. Next, we hypothesized that the difference between the vulnerable populations and all other countries is a result of access to COVID response. So here we look at the difference in the average number of hospital beds and vaccination rates throughout the course of pandemic. And we found that people in high poverty counties are less likely to be vaccinated or have access to hospital beds than people in other counties. Importantly, the relative gap in hospital beds in high poverty areas only grew over the course of pandemic. When it comes to low physician access areas, we also see this uneven vaccination rate and uneven access to hospital beds. Next slide, please. Stephen, over to you.
Yeah, and so when we think about how we can improve care in medically underserved areas, the intervention that we, the healthy hackers, were especially interested in was telemedicine and telehealth platforms. And so telehealth is essentially the use of information technology to facilitate virtual healthcare services, patient-provider interactions, public health, and health administration. And so some of the telehealth services that should be offered during the COVID recovery include COVID-specific services such as COVID-19 testing appointments, vaccination appointments, contact tracing, and symptom monitoring, as well as more general services such as virtual consultations with clinicians, mental health services, including psychiatry and grief counseling, health screenings and monitoring for chronic conditions, which has decreased significantly due to the pandemic. So we should especially be screening for cancer, diabetes, hypertension, and other chronic diseases. And then also just data collection and case reporting of some of these metrics. Again, COVID cases, chronic disease cases, and other important metrics. And so it's important to note that some of these services at some point will need to take place in person between a patient and a provider. However, virtual platforms can triage some of these services to safer locations that are actually equipped to provide them. Next slide, please. And so when we consider what a telehealth or telemedicine solution should accomplish, in general, we want to accomplish three things. So first, lessening the burden on patients and their families. Second, maximizing that access of the patient to support systems. And third, tailoring specific technologies and methodologies to enhance patient and family needs. So it's our belief that telemedicine and telehealth could have prevented excessive COVID cases and deaths among lower income Americans. And as the nation continues to recover from the pandemic, these services are going to be essential to ensure that lower income Americans have access to quality, cost-effective virtual healthcare.
Thanks, Stephen. I'm just going to talk very quickly about some of the challenges we face and caveats to the analysis. So one of them is, we talked about it a little bit earlier, but we're using a very imperfect definition of what it means to be underserved by the medical community. The HRSA has like a complicated index that we use to define that. We're using a couple of facets really, of their definition, high poverty and low density of physicians in the population, to sort of, understand a portion of what it means to be medically underserved, but it certainly is missing people there. A couple of these are sort of like self-explanatory, but I'll explain one more. The physician count information that we have does not include all physicians. So what we're looking at here is people who have MD and DO degrees, primarily people educated in the US. We did not have data on foreign medical graduates. So, there are, most of the physicians in the US are included in this data, but the ones who are not, if they're sort of disproportionately located in high poverty or low poverty areas, for example, that could have a systematic effect on the analysis that we presented.